The third case, I'll do it very quickly. It's another patient we managed. You can see she's very different. She's one of the rheumatic heart disease we manage, and we had about 15 cases of severe mitral stenosis out of 65 cases. She's a 40 years old UAE national, para 5 plus 1, and she's booked at 6 weeks in Cornish Hospital. She says it's a spontaneous conception, DCDA twins, but we have doubts whether she had taken some, ovulation induction medications. We are not sure, as she's with a high BMI of 35. Her previous obstetric history, she had 5 normal deliveries, and the last childbirth was in 2015. Between the 4th and 5th child, she had 1 termination of pregnancy during the first trimester. Her medical history, she's apart from rheumatic heart disease, she was diagnosed as a case of epilepsy in 2016, and she's also having migraine. The diagnosis of rheumatic heart disease was made in 2011 when she presented to us at 36 weeks with severe preeclampsia, and later she developed pulmonary edema, and she has been induced and delivered vaginally at the same time. At that time, the echo showed she had mild mitral stenosis with moderate mitral regurgitation. The same year, actually she delivered in February 2011, and again she conceived in May 2011. So this is the time she was seen by a cardiologist in the other facility, and the cardiologist advised termination of pregnancy. They did a pre-exercise and post-exercise echo and assessment, and the recommendation was made to do a termination because of the values after the exercise. Pre-exercise, she had a peak gradient of 11, mean gradient of 9, and the mitral valve area of pressure half time was 1.4. And the PA pressure showed 27, and the after exercise, the gradients were high. You can see 44 and 29, and the PA pressure rose to 47 to 50. So at this point, they concluded that she is having a moderate mitral stenosis at rest, and it becomes significant hemodynamic impact after the exercise. So she had the termination with us. After that, she was offered intrauterine contraceptive device, and she was commenced on bisoprolol 5 milligram daily. And she had a follow-up with cardiologists, but not very regularly. And the echo in November 2012 showed her mitral valve area was 2.4, and she was quite asymptomatic, but I think she stopped the bisoprolol by herself. And again in 2015, she fell pregnant again. This is the 6th pregnancy. She presented to us during second trimester. At that time, we did an echo which showed a moderate mitral stenosis. Again, the valve area was 1.6 with a peak gradient of 20 and mean 7. She didn't have any significant pulmonary hypertension. So again, we commenced her on bisoprolol and followed every month, and after 28 weeks, almost every 2 weeks, and she had an uneventful pregnancy delivered at 38 weeks by induction of labor, which is vaginal delivery. After all this, she presented with multiple episodes of seizure to one of our Sheikh Khalifa hospital. There she had the workup. And then later in Cleveland Clinic, they confirmed that she has new onset epilepsy. And she was commenced on levetiracetam 500 twice a day, which she was taking regularly. Then she followed in Cleveland Clinic, and with time, she developed more severe stenosis, and they did a mitral valvotomy in 2017. Post-procedure, her valve size was 2.4 centimeters. Then she removed the ICD early last year because she wanted to have more children. So the 7th pregnancy, she presented at 7 weeks. This is the pregnancy I'm talking about. This is a twin pregnancy. And that time she was on Keppra and folic acid 5 milligram daily. So when we first saw her in May 2022, just prior to her current pregnancy, the valve status was moderately severe MS with a mean and peak gradient 14 and 9, and the area was 1.1 to 1.3 centimeters. So this patient was extensively counseled in Cleveland Clinic about the risk of continuing a twin pregnancy, but she was very adamant that she wanted to continue this pregnancy. So she came to Cornish Hospital. And at that point, she was on metoprolol 50 milligram twice a day. And we followed her every 3 to 4 weeks, and initially by every month, and after that every 2 weeks. But again, this patient also DNA'd couple of her clinics. At 22 weeks, the echo showed the same finding. At 26 weeks, she became very symptomatic. We did serial BNPs, but those were not very high, but patient was very, very symptomatic. And so we have to start her on diuretics. And we scanned her at 26 weeks. The scan was equal to the dates. The baby sizes were okay. Very first twin 850 grams and the second twin 830 grams. It is appropriate for her gestation. But again, at 27 weeks, she became more and more symptomatic. The dose of metoprolol was increased to 50 milligram 3 times, and the diuretics have gone up to 40 BD. And you can see the serial echoes in different trimesters. The valve area is the first trimester 1 to 1.2, second 1 to 1.2, third 1 to 1.1. And the gradients were also going up, and the PA pressure now reached to 50%. So we have to admit her electively at 28 weeks, and she received steroids for lung maturity. And this patient is a candidate for tubal ligation. After extensive counseling, she had cesarean section and bilateral tubal ligation. This time she had combined spinal epidural anesthesia, and the EBL was 200 ml. And she was discharged in a stable condition on metoprolol 50 BD and furosemide 40, and recently her furosemide was discontinued, and she's currently only on metoprolol 50 milligram twice a day. And again, she DNA'd 2 times the clinic, and she's again referred back to her cardiologist in CCAD. And both babies were in NICU for about 7 to 8 weeks. And the twin one at birth was 1.14 kilos. Now it reached to 2.48 kilo, and the twin 2 was at birth 1.13 kilos, and now they reached to 2.88 kilos. And both babies were discharged, and they are doing well at home. Thank you.